Hello, I'm Dr. Bridget Nash, and I'd like to welcome you to The Therapy Show, a podcast series dedicated to helping people navigate the mental health system. Dr. Justin Capote, I would like to highlight your experience working in hospital inpatient psychiatric units. Going forward, I will just use the term inpatient psych when talking about this hospital service. From your experience working in community hospitals in the tri-state area, what are some of the main reasons someone would be admitted to inpatient psych?
Well, straight away, it's going to be the most serious presentations of psychiatric disorders. So acute psychosis in someone with either a severe bipolar disorder or a schizophrenia spectrum disorder, suicidality, suicide attempts, a suicidal intent, behavioral disturbances, so people acting out in the community do get hospitalized if it's felt that that behavioral disturbance is due to a psychiatric condition. Depending on the kind of unit you have voluntary inpatient psychiatric units, you have involuntary psychiatric units, you got geriatric inpatient psychiatric units, so it'll run the gamut. But generally, if you find somebody in the emergency room with a psychiatric condition and their behavior is causing a threat to themselves or other people or in some way impairing their ability to live safely in the community, they're going to wind up on the inpatient psychiatric unit of that hospital.
And so what about a person, let's say, with substance use disorder?
So that's an issue that's getting a lot more attention. I was listening on the radio about how rehab centers and substance use treatment centers have sort of operated outside of the lines of conventional medical treatment, and as such are really a lot more, well, I don't know if it's profit driven, but yeah, I imagine I think pretty straightforward, sort of more about keeping the beds full and keeping that sort of revolving door going. And as the opioid epidemic has engulfed the better part of the country, we're starting to look at substance use problems not as moral failings, but perhaps as biological conditions that do require medical intervention and good quality evidence-based medical intervention. So it's tricky. If you've got a unit that isn't labeled as a substance abuse treatment center, it gets tough to hospitalize the middle-aged man who's isolated in the community and has been drinking and presents either after a suicide attempt or with strong suicidal intent. You've got to, if you're going to hospitalize them and there isn't a substance abuse treatment center, you start getting into that familiar turf war. Well, the substance abuse place won't take them because of the depression, and the adult psychiatric unit won't take them because of the drinking, and it becomes this sort of tug and war. So I guess the answer to that question is that's a bit different. Substance use disorders might get you on inpatient psych, but the long answer is it depends.
And I remember this from working at the hospital. Not all inpatient psych units are certified, or they are not all designated as substance use treatment centers. So I think that's a tricky issue with the regulations, the hospital regs.
That's right. And so when you hospitalize somebody who does need a detox from alcohol or benzos or opioids, and that's not a designated center, as clinicians, we want to do right by our patients. We want to do the right thing, and holding them in the hospital is appropriate. And if the detox isn't severe enough to warrant medical admission, which it sometimes does, we've got to come up with an Axis 1 condition. I know they did away with the Axes already, but we've got to come up with a primary psychiatric diagnosis, mental health diagnosis.
So what might a person expect to happen to them in inpatient psych?
Well, number one, it differs from any other floor on the hospital because it's a locked unit. So you can't go and come as you please. That's number one, which certainly if you've never been on inpatient psych before, that whole process to entering can be a bit unpleasant and a bit jarring. That would be the first thing to get over. Visiting hours differ somewhat as well. They're a little more strictly enforced. There's set times, people sign in and sign out. There's a lot less access to the people if you were hospitalized on any other floor of the hospital. The other thing that you notice is people are generally in plain clothes, and it's not a medical unit, so there aren't the familiar hospital beds or IV poles or buttons. In fact, everything is specifically engineered and designed to not be detachable, to not be able to be used or broken off on yourself or on someone else. So safety is a big one. Because honestly, the reason if you're up there, safety is the number one reason why people are going to be up on inpatient psych. So once you're there, the shower curtains tear off, the curtains on the windows tear off, everything's rounded, there's no faucet handles, things like that. What else?
Let's talk about the relationship of the unit where you have this, like the multidisciplinary team and how that's structured.
So, I mean, I guess, ideally the way it runs is you present to the hospital with a psychiatric emergency. You're evaluated in the emergency room. You're deemed to have a condition that endangers your safety or the safety of the people around you, and you make it up on inpatient psych. So obviously the job of inpatient psych is to stabilize that acute problem. Psychosis or mania, suicidality or agitation, that's the work that's being done first and foremost. But because that list of presenting problems can really run the gamut of functionality, you've got high functioning people, meaning these are people that hold jobs or have families and pay mortgages, to people that are lower functioning that have much more severe persistent mental illness where they aren't in the workforce or they don't own homes. Maybe they're living in group home situations. So the demographics, the patient population on inpatient psych can vary. That often needs to be addressed. There's no one size fits all. But ideally, it is about safety. It's about stabilization. It's about working through the presenting problems. So if we're talking about inpatient psych, we've got to talk about the reasons why you're there. Someone in their late teens that made a suicidal gesture is very different than someone who is in their 70s that has dementia and lashed out at family members, is very different from someone in their 30s who's had a dozen hospitalizations for decompensated schizophrenia and is back after abruptly stopping treatment or what have you. So these are certainly immediate challenges that inpatient unit has to, the sort of triaging of people. But if you're new to the unit, that's going to be jarring. That's going to be something that, depending on the unit, depending on the milieu that you're introduced into, there's going to be an acclimation process this first couple of days, this first day or two. And
working in a psych unit, I notice that you work with this team, and the team consists of a psychiatrist, maybe a social worker or a licensed professional counselor, and then you'll have mental health techs, which are really amazing.
I was going to say, generally the most spirited people on there, the most sort of eager, are the techs.
Yes. And they spend a lot of time one-on-one with patients. And we call them patients because they're in a hospital setting. And I think that what people don't realize is an inpatient psych hospital unit is run by these well-trained inpatient psych nurses.
Right.
Who with the techs really interact with the patients. And then, maybe the psychiatrist will be overseeing that. Can you talk a little bit about that?
Yeah, I think that's right on. I think the day-to-day work is going to be primarily carried out by your psychiatric nurses and the people that they employ, the people that are helping them with the day's tasks, running groups, medication times, checking in on people, and then just sitting and doing sort of one-on-one therapy. The psychiatrist, generally, most places will round with the staff in the morning on every patient there or whatever patients are on their caseload, discuss the issues that be, any behavioral issues, any things that they've voiced, any ongoing symptomatology, side effects to medications that were started, and then the psychiatrists make their rounds with patients on the unit. The social worker becomes indispensable on the psychiatric unit, certainly from the psychiatrist's perspective, because, and certainly over the last several years, the push to disposition patients, in other words, the push that from day zero, what's the discharge plan? Who are we reaching out to? Who are the people in the community? What does the discharge plan look like? What's going to be the level of care that they need? And that sort of thinking, that planning starts from day one, which is a good thing, but it can also be a sort of a bad thing. If you're hearing that, you're feeling, well, isn't there then pressure to sort of move people out? Yeah, I mean, there's really no bones about it. That's certainly the way that it's become the sort of length of stay issue that you sort of face. But I'm sure we can jump into that in a little more detail. But on the surface, yeah, where the psychiatrists are overseeing, social workers are gathering collateral information from the people in that person's life, and we're coming up with a plan. Psychiatrist is going to come up with medication, primarily medication management. If you're being admitted to the hospital, you will be started on psychotropic medication. Nowadays, I don't know of any place, any inpatient psychiatric unit that you would go and not receive some sort of psychotropic medication and be discharged with some prescription. That is sort of part and parcel with the experience.
Well, talk about that, because is it just one medication? Is it more than one?
Yeah, I mean, I think it depends. I know when I started my inpatient training would have been 2000 and 2009. Inpatient between 2009 and when I was a senior back on the unit, 2013, things were very different already just in that 4-year period of time, where in my first year, people commonly would stay for a few weeks at a time. There wasn't sort of active medication management on a daily basis. And to be sure, a lot of the medications that we use, specifically SSRIs, may take weeks before they're demonstrating any therapeutic effect. Even antipsychotics, which work very quickly, it still could be several days and maybe a week or two before we're really seeing persistent therapeutic benefit. But whereas, at the beginning of my training, people would stay for weeks, even a month or a couple of months, although a couple of months, I guess, was rare when I was started. But certainly by the end of it, 4 years later, 10-day length of stays was the drumbeat coming down the chain of administration. No, 10-day length of stays, 10-day length of stays. Insurance is dealing with insurance, calling insurance, arguing with insurance became a daily affair, whereas 4 years prior, it really wasn't that big of a deal. I remember in my senior year, and I took the brunt of the insurance work from my underclassmen, from my first and second years that were training, and let them focus on the actual quality of work that they were doing. But I remember saying to an insurance, I think it was to a psychiatrist, or that it was kicked up to MD review. Because sometimes you're going to talk with a non-MD. You're going to talk with a non-healthcare professional that has a checklist of things that need to be satisfied in order for them to continue paying for hospitalization. I'll never forget this young guy who had a pretty disabling psychotic illness that ebbed and flowed, that flared and didn't flare. And he was prone to acting out in the community. Well, he comes in after a skateboarding accident with this really gnarly fracture in his leg. I mean, I guess it's a really long story because it was back and forth between hospital and orthopedics and consenting for surgery. And it was this really big how to do case. But anyway, he gets the surgery, leg is immobilized, he's in a wheelchair and he's back on the unit. And he is by no means better. But I remember arguing with the insurance carrier that because he wasn't agitated enough, he didn't meet criteria for hospitalization. And I remember saying to the insurance carrier, look, I promise you, if he had the use of both of his legs, he would be up and getting into trouble. But it's the fact that he's in a wheelchair that he hasn't actually gotten up and acted out. I remember another man who was there for suicidality, made a pretty serious suicide attempt. We'd worked with him for a couple of weeks. He was going home. We had it set that his brother was going to pick him up and escort him home to his apartment. Insurance wouldn't pay for that extra day. And I remember going so far as to say, this man will kill himself if he goes home today in order to get insurance to just simply pay for the overnight. I don't know what happened over those couple of years, but it really became less about what the patient needed and more about just meeting certain criteria for reimbursement. I know that sounds kind of cynical, but prove me wrong, I guess. I invite people to give me examples to the contrary. Maybe it's the places that I've worked, but I've worked in several places, several inpatient units, different socioeconomic areas from low to high, and it's true everywhere. Double-digit length of stays are not a thing anymore. It's rare, and if you're getting there, that unit is looking to disposition you somewhere. This same kid with the broken leg, I remember the insurance was saying, look, we're not paying for him to be inpatient anymore. Either send him home or send him to the state hospital. For clinicians, that's a ludicrous suggestion because you're talking about dispositioning this boy off of the unit. And he was in his late teens, either home, the lowest level of care, or to a state-run psychiatric hospital, the highest level of care. In their eyes, it didn't matter. Either send him home or send him to the highest level of care in the land. Just get him off the unit. It was remarkable. So
you're telling me that you, Dr. Justin Capote, who has the medical degree, and all of these years of experience, you're talking to insurance companies.
Yeah. The tide changing. I remember I was a second year resident and I was calling about a woman, high functioning woman, but a bad recrudescent bipolar disorder. Very psychotic, non-functioning, really not able to meet her day-to-day needs. And I'm explaining this, but I'm explaining it to an MD to MD review. Insurance was getting tired. She was there. It was already 2 weeks, 3 weeks, whatever. And they were, gotta move her. And I'm talking to the MD who was clearly older than me. And I was obviously clearly a trainee. And I'm explaining this. And I remember he says, look, I'm going to approve the days, but in the future, you got to make them sound sicker. And that was a professional courtesy, believe it or not, because he did approve the days and we had her until we needed to. He gave me sort of carte blanche to treat her, which is nice. And it sort of shows that preserved somewhere in this process is the desire to do right by our patients, by whomever comes to us for help. We want to do right. 2 years later, I have to literally threaten that this person may kill themselves or wind up dead if they don't have another hospital day. Just one more. It's unpalatable. It's become quite unpalatable.
But think about it. Don't you think there's a better use of your time?
And arguing with insurance, yeah. They've outsourced those jobs since, because now that's become a job on the unit where someone is, their role is to simply just get approval for days. That it became such a problem that now people are hired specifically to do that job on inpatient units. The last place that I worked, there was somebody dedicated to that and would review the notes and would pull you aside and say, look, I need something to bring to the insurance company to get a couple of more. All right, they're going to give us till Thursday. All right, we got until Monday. All right, we got 2 more days. This became the running of the unit from at least from the MD and the social workers. And
that's generally a nurse, correct? Or it could be a social worker.
Yeah, I guess you just need you need familiarity with the treatment being provided. You need some sort of mental health experience.
Wow, pretty remarkable.
Yeah. The use of medications, I think, going back to, I got carried away, which this topic will cause me to do. So if I ramble, apologies. But the number of medications that you're discharged on, I remember working on an involuntary unit. I never used more than 3 medications at the same time from different classes, a mood stabilizer, an antipsychotic, and then a benzodiazepine for my sickest, loudest, strongest patients. That was a regimen that I would lean on. Now I've seen on voluntary hospitals people discharged on upwards of 5 or 6 concurrent psychotropic medications. And again, if you couple that with the dwindling length of stays, if you're saying that someone's leaving on, let's say, 4 or 5 medications in a 7-day period, that's just simply not long enough to even know if those medications are tolerated well, let alone efficacious. And working on consults and inpatient, you'd see some people who were discharged. This didn't happen a whole lot, but I can certainly remember a couple of cases where I'd been consulted on someone on the medical floors several weeks after they were discharged from inpatient. And the story was, they were discharged on 4 meds 3 times a day in different combinations, and admit to me weeks later that I couldn't keep track of this regimen, so I just stopped. And then whatever happens, happens. Yeah, I saw a woman come in benzodiazepine withdrawal because she really didn't remember or didn't have pinned down the increase in benzodiazepine she was given on the inpatient unit. So the handoff is super important. And if you're under the pressure of length of stays and constantly trying to defend the need for hospitalization to insurance, you can see that this sort of quickens the treatment, advertently, inadvertently, whatever. This is going to quicken the treatment. And so sometimes handoffs can be rushed from inpatient to community. And depending on what kind of programs you have to discharge to, intensive outpatient, partial hospitalization, or just straight up weekly medication management, ensuring that handoff is, sometimes that can be tricky too.
And one of the things I notice is working on an inpatient psych unit. And again, one of the things I think people with mental illness experience is issues with sleep. So oftentimes I've noticed that a sleep agent will be put in place. And what I mean by a sleep agent is like a sleep medication.
Yeah.
Or even a psychiatric medication that induces as a side effect sleep.
Mm-hmm.
But I noticed that these are heavy medications and they're useful in the unit, but are they going home with like trazodone and medications like that?
Seroquel and Ambien.
Seroquel.
Yeah, generally you're going home with these things, and in my experience working outpatient for some patients that had pretty serious major psychiatric disorders, that they were hospitalized with some frequency, or people with significant personality disorder pathology, where they wound up on inpatient units with some regularity. These people were probably more likely to be exposed to polypharmacy like that, and part of my work in outpatient with some of my people were to say, look, when you get inpatient, I'm never going to discourage somebody from going to the emergency room if they think they need to, ever. If that's in your coping kit, then you go to the emergency room and you give them my information and we will collaborate on what the next step is going to be. If that's where you'll be safe, go, right? But if you're presenting with suicidal ideation or after a minor suicidal gesture, you may get hospitalized or at least put in observation. But again, that's going to come with this almost obligatory medication management. The sort of justification, well, day 0, we're increasing antidepressant. Day 1, we're going to be adding a sleeping pill like a trazodone or a Seroquel. Day 3, we're going to increase the antidepressant. Day 4, we'll add a mood stabilizer. Day 5, and these sort of things where I'll say to my patients, ask, what is the benefit of this, or what can I expect from this, or why is this changed? Certain patients would come back after a hospitalization on a whole new set of drugs, and you can't just do that. I mean, if somebody's been on these medications, an antidepressant, for example, for a good length of time, an SSRI, I've seen this happen a couple of times where they'll come in with more of this sort of flattened affect, loss of energy, and they've been on Zoloft for several years, and then we'll just be switched straight up to Wellbutrin. Well, those drugs don't work the same way, and within a few weeks, that person's in full-blown withdrawal and don't know what's happening. They think the depression's gotten much, much worse, and antics ensue. So I think when patients are discharged on regimens, it's really important for them to understand what changes have been made. And a lot of the time it's arming the patient with the knowledge to ask, okay, I see that you're switching my antidepressant to something else. How come? Or I see that you're increasing the dose. What are we looking for? What am I to expect? Because again, we're talking about short length of stays. So the therapeutic benefit to some of these changes may not be realized until long after the patient's out of the hospital.
Benefit or
consequence, right? Yeah, I mean, again, when I started medication, the first couple of weeks are tolerability. We're checking in frequently to assess for tolerability issues. Okay, are any stomach side effects or dizziness or rashes or anything untoward? And then in week 3, week 4, week 5, we're starting to weigh in. Okay, are we actually starting to see some therapeutic benefit? And then if not, okay, then we'll go ahead and titrate the dose. Maybe that's overly conservative. I don't particularly think so, but I don't think that titrating drugs that are recommended to be titrated on weekly or every other week basis over the course of 10 days is beneficial for anybody.
Okay, so depending on a patient's psychiatric evaluation, what are some of the possible scenarios a person might experience when they're in an inpatient psych setting? And one thing comes to my mind is that it's mainly group driven, like the milieu. When we talk about the milieu, that means it's a group therapy milieu. That's right.
And I think that can be very beneficial if you've got a good breadth of groups. Because again, the people being admitted to inpatient psychiatric units are there for myriad reasons. So if you've got a substance abuse group, there should also be a coping skills group, maybe a bereavement or grieving sort of death and dying group. But depending on what you can't have sort of generalized groups for everyone on the unit because some people aren't going to get much out of it. But at the same time, I know in terms of criteria for discharge, we kind of mandate that people go to groups, regardless if they get something out of it. We want to see that you're participatory in the milieu. We want to see that you're attending groups, that people are seeing you, and that you're acting right. I mean, I've said it before to patients that were still behaviorally a problem. I said, look, it's not hard to get off the unit. That you're not able to satisfy our concerns about you says something about your impulse control. And when people hear that, they go, oh, okay. And you start to see this more external attempt to restrain. But again, that would be referring to more of the SPMI or the severe persistent mental illness population. You got higher functioning, mostly depression or bereavement, panic, life stressors, the loss of a loved one, or things that overwhelm people that drive them perhaps to substance abuse issues or to suicidal fantasies. They're also on that unit, and they need a whole different kind of intervention. There, we're sort of shoring up self-esteem and resilience and trying to refine purpose and meaning and put a strategy together where someone who's decompensated schizophrenia, as it's been put to me in the past, we're sort of ego lending. All right, get up and brush your teeth. We've got to change our clothes. No storing food in the mattress, and these kinds of things that seem obvious to higher functioning people that aren't. So again, the interventions really do depend on what you're there for. Units that blend, that sort of one group fits all aren't gonna be the most specific interventions. They're gonna fall short some days.
And I think people do not realize that you may see your psychiatrist, you may see psychiatrically trained nurse as well, but you're not going. It's not where you're going to get individual therapy like you would in an outpatient setting. And
no.
What was explained to me is this is not the setting for it because you're going to be discharged. You don't want to open up issues that are very intense in that setting. So that's what I meant by that. You'll see your psychiatrist, you'll see the nurses who are
but
fantastic.
It's going to be more of a supportive environment. We're going to get, but at the same time, I mean, you're there because something boiled over, and that at the very least needs to be sussed out and addressed. So you're right. This isn't going to be intensive individual psychotherapy. It's not. It isn't. It's going to be a lot more heavily group therapy focused. And if that's something that you've got an issue with, that will present itself as a barrier. No, but you're right. It's not therapy. It's a timeout. It's a timeout button. When I've had people on the medical floors who needed to be hospitalized after a suicide attempt, I said, look, you've got to appreciate it from my perspective as well. Your safety is my business. You can promise up and down, but I've got an obligation to make sure that you then now enter this next phase of treatment. We've stabilized you medically from your overdose or from your wounds. And now, for whatever it's worth, you've got to spend time on inpatient psychiatry talking about this. I've heard it put to me this way, the flight to recovery, people sort of wake up in the hospital the next day and go, oops, no, sorry, won't happen again. I don't need to do this. This was a mistake. I'm sorry, I'm gone. And it will be a really ambivalent thing to go on inpatient. So the way I try to phrase it to make it more palatable is this is a timeout. You're here. It is a reflection on the point that you got to out there. Things boiled over, and here we are. This is you needing pause. So let's take advantage of that pause. Let's take advantage of that timeout. Let's take a deep breath and let's do our sort of crime scene analysis. Let's back up and see what are the reasons, what are the things that you got here for, what's been going on, and talk about it in a non-judgmental way. But that does require both group and individual. People that comprise the group have a lot to do with how that group feels and runs. So it's tough. When you've got people staying on the unit for weeks at a time, it was a different kind of community meeting than when you have people, literally new faces every week. It's going to be a different feeling group. You know what I mean? Sure.
Working now on the outpatient, one of the things I've noticed is up until 18, you go to an adolescent psych unit. At 18, you go to an adult psych unit.
That's right.
And I've had a couple of outpatient clients who were traumatized at 18 in a month, really more appropriate for an adolescent unit, was mandated. It was maybe a suicide attempt or gesture or even just ideation, mandated to go to an adult unit. And as you mentioned before, it's 18 to whatever.
To infinity, yeah.
To infinity. And so it was actually the treatment that traumatized more the patient than the act. I don't know. It was just incredible.
I've had that echoed to me with other patients in my outpatient experience, where even when they're doing poorly, they really want to avoid inpatient hospitalization because it has been a bad experience for them before. And that's just a shame, because in the same way that emergency room work and consult work, the value of it is the saliency of it. Inpatient is the same. Hey, this is happening. We can't look away here. This is a locked ward, so you and I got nothing to do but talk about what's going on.
My point is it fair to put an 18 plus 1 month adolescent in a unit that is really more appropriate for an adult?
No, but then the parent of the 9-year-old on the child and adolescent unit may not want their 9-year-old in the same environment that sort of aggressive 18, 17, and 18-year-old kids are in. So, I mean, it's unit dependent, and the milieu on the unit changes. When I was doing inpatient psych in training, we had a mixture of voluntary and involuntary people. The community meetings, really, the tenor of them were dependent on the kinds of people. If we had many people that were there for acute mania, those were lively meetings. If we had mostly people with decompensated schizophrenia or bad depression, nobody talked. So the milieu of the unit changes for sure. I think that to deal with that, the clinicians themselves need their own sort of process groups. They need their own community meetings. They need their own outlets. They need really good work-life balance. They need to feel valued. There needs to be things that improve their morale. I remember making the switch in residency from doing my internship on the medical floors, which I enjoyed a great deal, to then switching to inpatient psych. It felt like everything just came to a halt. I was pulling 80-hour work weeks, and then those were dropping to 50, 60-hour work weeks. But I left feeling worse. I left feeling a lot more drained, a lot more conflicted and ambivalent and raw. And it's a different line of work. So you can't expect people to just churn them out. It's just not the nature of the work. But when you see 10-day length of stays for acute mania, you got to wonder.
And I think that from what I've seen, think about it, like if people can imagine. And what I meant by environment also is you're in this locked unit. It's double doors, and then you're in, right?
Yep.
And
right.
and the people like you and other psychiatrists and social workers that I've worked with and the mental health techs, they care about their patients. And so that is very stressful for them because it's hard for them to feel so powerless over. That's right. I think they know what's best for the patient.
I haven't thought of it that way. That's actually a really great point. You're right. I mean, if you're working on an inpatient psychiatric unit, you're not doing that, for the summer. That's not something that you're doing just to make a little bit of extra money when you're home from college, right? You're doing that because there's an interest in the work, like you kind of care. I think that's true because it is emotionally challenging work, and people aren't just deciding to do it as they would, sort of other jobs. And then I can tell you from a trainee's experience, being a trainee and being raised in an environment where it was really patient first and Hippocratic oath and all of these things, and then moving on and becoming an attending and working in clinics and hospitals and going, oh, what have you done?
So what do you think are the positive aspects of being evaluated and treated by a mental health professional, like a psychiatrist or social worker in an inpatient setting?
Of course, it's safety. And like I was saying earlier, if I have patients where part of that safety plan is going to the emergency room until the dust settles, yep, that's the advantage. It's safety, first and foremost. This is a bit of a digression, but when we talk on medical floors of people with dementia or other sort of major cognitive disorders or physical limitations where they're not really able to be totally safe in their home, there's the call to, they got to go to rehab or they got to go to assisted living or a nursing home. And again, what we're talking about is safety. Well, they're 100% safe, but 0% autonomous. And I think that's the constant balance of it's safety versus autonomy.
So what do you think are some of the pitfalls of being evaluated and treated by a mental health professional in an inpatient setting?
It's the time, it's the pressure, it's the length of stay, it's the need to medicate every single day. It's the emotional tax on your clinician wherever they're at that day is going to be reflective of the attention and interest that you get. It's a really personal experience. And I mean, the pitfalls are the system that is in the way of good quality inpatient work. That's the biggest problem.
And you would say that's mainly insurance driven? Or is it policy driven?
Yeah, I mean, it can't just be insurance driven. Inpatient units are acquiescing. When that insurance agent says to me, well, you were the ones who told us 6 days was enough for acute mania. If that's true, then these decisions are being made above the heads of the actual people providing the care. And what we're being told is you have until Friday. What we're being told is you've got to start more meds. What we're being told is you got to start working on discharge on hospital day number 1. I don't know if it's just insurance or if it's hospital administration or a little bit of both. I'm not privy to that knowledge.
Or the capitalist system.
Yeah, the businessification of medicine in general since the 90s.
Did you make up that name?
Businessification? Yeah, it's a Capote original.
I love it. So what are you most excited about in mental health treatment today when it comes specifically to inpatient care?
I'd like to think when we talk about like state hospitals here in New Jersey, for example, they should be bastions for research and development. They should be where you go to enter trials on things that are new and cutting edge, where you have access to all of the transcranial magnetic stimulation and ECT and ketamine that's gotten some press or psilocybin that's also gotten some press or what have you, but really specific tailored intensive group therapies, relational or substance abuse or dialectical behavioral or CBT. But it isn't. It's not. It's the opposite. This is a question about what I'm excited about, right? I don't know.
Yeah. Well,
I don't know.
Let's just move on to the next one, which is, Dr. Capote, if you had a magic wand and could improve one thing about mental health treatment in an inpatient setting, what would that be?
The absence of managed care. That's easy. Just a communal investment in the necessity of it. It's the monetization of it. That's what I would remove if I could remove something. If it looked a particular way, it would really be about returning people to their lives in a better way than they came in. And there would be a richness of therapeutic modalities. There wouldn't just be interns tasked to run a group by themselves with little supervision. There would be excessive supervision. People would stay as long as they needed until they could leave. And if people were invested in staying and that was the pathology, then we would work on getting them out. But it would be thoughtful and tailored, and there would be process groups among the clinicians as well. It would look different. It would be a different thing than it is today. But I think inpatient psych has always kind of gotten the rap right. I mean, in the 19th century, it was that. It's been described as there was outside time and there was arts and crafts and music and things. And then it became this sort of custodial role by the 20th century, bedlam and those sort of negative connotations. And then there was deinstitutionalization in the 50s, and because people didn't need it anymore, and that didn't turn out well, and people bounced back. And ECT and One Flew Over the Cuckoo's Nest in the 70s, another bad spell. Yeah, I don't know. It's so mired in stigma. It's hard to advocate for it, but it can be a really valuable resource if it's treated as such. But I feel like the policy treats it more as a way station than a turning point.
That's interesting that you described the actual structure of inpatient psych having an actual stigma, just like mental health has a stigma.
Sure.
So on that note, Dr. Capote, on behalf of myself, my listeners, and all of the people that you have helped through your work, I want to thank you for your contributions to mental health treatment.
Thank you. Thanks for having me. This was a sobering discussion.
So I'd like to close by reminding our listeners to please subscribe, share, and review this podcast so you, someone you love, and the people around the world can gain more benefit from mental health treatment. There is no need to suffer in silence. Get the help that you need and build the life that you want.